All right. Well, a very warm welcome to all of you. As you know, it is our great pleasure to host the Resident Reviewer Development Program. The program has grown steadily over the years, and we've had some fantastic graduates, including tonight's speaker. We've had some wonderful folks go on to become star reviewers and folks who have really made us proud. And certainly, Dr. Sethi is among those. Very, very pleased to welcome Dr. Sethi here today to speak with you all. Dr. Sethi is a graduate of Yale College, and he obtained his medical degree from Harvard Medical School, and also got an MPH over at Harvard as well. Did his residency in the Harvard program, and then went over to Michigan to do a head and neck cancer fellowship. Since even he was a research fellow amidst residency, Dr. Sethi has had a strong interest in understanding cost, price, and economic concepts that I think are not always straightforward for people to understand. But fortunately for us, Dr. Sethi has brought a lot of great expertise into this area and has really opened our eyes in terms of different ways that we can look at new concepts such as price transparency. I think these concepts are really important as you all learn to look at papers. We do get papers that come in that have economic concepts, and we'll speak about things that have definitions such as cost and charge and price. I think really understanding the nuances and the differences between those different things is really helpful. And Dr. Sethi is definitely an expert in this area, having been quite an interest of his for some time. I will also very proudly share that Dr. Sethi is actually the this year's winner for the William Montgomery Teaching Award, which is bestowed upon a favorite teacher from the Harvard residents. That's right, Isaac, you clap, I'm with you. It is truly an immense honor. And as I have said to prior winners of the award, I think many awards are a sign of respect, but this is a true sign of real love. Dr. Sethi, we are super proud of you to have you with us in our program. Really glad that you're here to help educate those who have matriculated into the Resident Reviewer Development Program. We're really looking forward to hearing your thoughts tonight. So thank you for joining us.
Thanks so much, Dr. Shin. Thank you for a very, very kind introduction. And as you mentioned, I went through this program, and I think it was really, really helpful. It's amazing that it actually exists. It's, I think, the only journal that has this program. And it's just an amazing way to kind of get exposed to the art and kind of practice of reviewing articles, get exposed to reading articles and manuscripts. So it's just a wonderful program. So you're all lucky to be a part of it. But thank you again. And we'll kind of focus today on thinking more about cost and specifically price transparency in healthcare. And I'm going to go out on a limb here and say that most of you haven't really had exposure to this or really any understanding of how this might work, although I could definitely be wrong, and I'd love to be wrong, but I'll assume you know nothing, so forgive me if you do, but we'll kind of go into the nitty-gritty and basics and some of my work in the price transparency area. So I have no disclosures, but we'll kind of go through the talk today just in a couple different ways. One is just a basic introduction to kind of my experience and interest in this field and how I got to kind of doing this type of research. Some basic definitions, like I mentioned, or Dr. Shin mentioned, about how we define charge, cost, and price in healthcare. And then specifically talk about some of the research I and others have done in this area in price transparency in otolaryngology. And then talk about implications of this type of work and kind of the future of our field in this area, and kind of more towards geared towards what you all do is kind of what to look for when reviewing a paper in this kind of area of research. So we'll start off kind of just with my background. So I was definitely that kid in high school who, and this is a true story, found the Gray's Anatomy textbook, the anatomy textbook, and memorized all the bones of the body when I was in high school. And so I knew from day one or day zero, I guess, that I wanted to be a surgeon. And so going into medical school, that was kind of, I knew that's what I wanted to do. And And then early in medical school, I started getting exposed to some concepts and ideas about cost and spending in healthcare that also stimulated my interest. And the figure you see on your screen here is kind of one that's shown in many, many different contexts. But this is a graph of historical and projected federal health spending as a percent of the gross domestic product. And I guess what was alarming to me when I first saw this was just how much and how quickly spending has increased. And I took a class while in college looking at the basics of healthcare economics. And again, this was a figure that I think I hadn't really appreciated then, but then being in the medical field and seeing kind of the amount of spending that was going on was quite alarming to me. And as an additional piece of background, I grew up in Canada, so it was very different than kind of how we thought about our healthcare spending, which was significantly less than in the US. So nonetheless, these two things kind of really spawned my interest in the field. And ultimately, that's what led to my kind of research focus. And I was very fortuitous to meet a very talented surgeon at the Brigham and Women's Hospital who is a vascular surgeon, Dr. Lewis Wynn, who this is kind of his area of work too, but it led to my first publication that was looking at market factors and how those impact adoption of endovascular aneurysm repair, which obviously has nothing to do with ENT, but was nonetheless an area that was quite interesting to me at the time, and even led to a research award and my first photographed kind of watermarked photo, which I thought was really fun. But this was kind of where I got introduced to big databases, kind of basic analytic skills in terms of quantitative analysis, spawned my interest in pursuing an MPH during medical school. That was also focused on quantitative methods. And actually, Dr. Shin taught a class on meta-analysis there, which I still remember quite vividly. But nonetheless, this is kind of where a lot of my interest really developed. So the paper I just showed was really looking at competition between hospitals. And we found a way to quantify this using what's called the Herfindahl-Hirschman Index, HHI, which I won't go into here in this setting, but really dove deep into kind of how we look at new technology. In this case, my interest at the time was looking at this new technology called endovascular aneurysm repair at the time versus open abdominal aortic aneurysm repair. And really looking at how competition between hospitals might impact earlier versus later adoption and how that might impact patient outcomes. So again, we use this novel analytic tool analytic measure called the Herfindahl-Hirschman Index, and it led to other studies kind of related to renal transplantation as well. But I say this just to kind of give you some context of how I got started in this. And perhaps an important disclosure is I'm not a healthcare economist, and I'm not kind of well-versed in all the nuances of healthcare economics, but just from a clinical standpoint, this was very accessible and something I was able to learn during the course of medical school and residency, and I think led to some pretty interesting work. So that's kind of where I started. And I just felt it was important to kind of give you some context to how I got into this. One more thing is I put these two up here, but the Agency for Healthcare Research and Quality and Healthcare Cost and Utilization Project are two very important kind of groups in the healthcare cost spending kind of analysis field. They're both government funded and release a lot of free publicly available databases. And you may have heard of them or read about them in other papers. HCUP, the Healthcare Cost and Utilization Project, publishes a lot of big databases. Ones that you may have heard of are the nationwide inpatient sample, the statewide inpatient databases, the emergency room database, the pediatric inpatient database, the KID database. So there's a lot of data that's actually generated by the federal government that's publicly available, de-identified, and out there for anyone to analyze. And that's actually where a lot of this work came from. So it's amazing what's out there and what really hasn't been tapped much into, but there's a lot out there. So kind of back to the focus of today, which is really looking at price transparency in otolaryngology and how we think about cost, charge, and price in healthcare in general. I think it's important to kind of really understand some key definitions. And these are, again, things you may know or may seem obvious, but in the context of healthcare sometimes can be interpreted quite differently. And it's really important to understand these definitions, both as you review papers or just kind of read about things in the news or talk to patients. So we'll start with charge. So charge is defined here as a dollar amount a healthcare provider or hospital sets for services rendered before negotiating discounts. So you can think of this as kind of, for example, if you're selling, if a brand is selling a fancy sneaker, they're going to have a suggested retail price. So it's kind of the price that the hospital, in this case, for let's say gallbladder surgery, the hospital says, well, we're going to charge $10,000. But that charge is somewhat arbitrary. Sometimes it's benchmarked based on other hospitals or other kind of regional market factors, but it's purely just a sticker price. And it is very different than the amounts that's actually paid to the hospital, which we'll go over here in a second. But just remember that charges are ultimately significantly higher than what is actually paid, and they are not equivalent to cost or price. So that gets us to cost, and cost can have a different interpretation based on the perspective. So a patient may think about this as the amount payable out of pocket for healthcare services. So that could be the total amount of their deductible, the copay, or really any other kind of cash transaction that's done or made by the patient. For a healthcare provider, cost might be interpreted as both direct and indirect expenditures to deliver healthcare services to a patient. And then the insurer would think about this as the amount payable to the healthcare provider for services rendered. But cost is a much more accurate estimation of what something truly, how much spending actually occurs. And we'll get to kind of how that is negotiated. And then price is very, very similar to cost, but it's essentially the total amount the healthcare provider or hospital expects to be paid by payers and patients for healthcare services. And on the converse side, how much an insurer actually reimburses for in this case example, a procedure. So once again, there's charge, there's cost, and there's price. Cost and price are much more similar to each other, but charge and cost are very different. So to kind of explain that further, again, I mentioned that there's kind of this suggested retail price kind of analogy here, but hospitals have what's called a charge master. So this is a list, an itemized list of all prices for all patient care services, whether that's a lab test, whether that's a provider visit, whether that's a surgical procedure. And prices are many times greater than the amount that's ultimately reimbursed. This allows hospitals to set a kind of a high starting point, and from that point, they essentially pursue closed door negotiations with insurances or whatever payer there is. And to date, that's typically never been disclosed, or up until now, that hasn't been disclosed. So this is an example. This is a joint replacement. So the hospital says that for the inpatient stay, they're going to charge nearly $100,000. But then in this example, this is a patient who's paying on their own. The patient gets an adjusted charge, which is the true cost of $33,000. Similarly, for the surgical outpatient professional fee, the hospital says they're going to charge nearly $4,000, but ultimately the patient's only paying $2,000. Now, this is an example of self-pay. If this patient had insurance, that ultimate adjusted charge would be significantly lower because the hospitals pursue a negotiation behind the scenes with different payers, and each payer might have a different ultimate charge or ultimate cost that they're willing to pay. But again, just an important concept to understand. And until I started practicing, I had no clue what my charges were, and I still really don't. Because it's in many ways irrelevant. Although patients will come up to me and say, doc, you charged $200,000 for that surgery you did. And my response is, well, I never saw any of that really. But I have to explain to them that there's, a negotiated price, and then ultimately they paid significantly less. But they do think that that I'm overcharging. But again, I really have no context for that. So I'll just again emphasize that charges are not a proxy for cost. So this was a response to a response, essentially to a letter response to a publication that was in JAMA Otolaryngology that was looking at cost associated with imaging surveillance for head and neck cancer. And in this case, it was estimated to be quite high. and the argument of that paper was that routine imaging is not necessary and is overly costly. But the problem here is that, again, they'd used charges as a proxy for cost. And this was completely incorrect. We actually went into that hospital's billing, kind of publicly available billing data, and found that it was significantly less than what they were stating. So this wasn't meant to be, like any tongue-in-cheek kind of criticism, but more so just to highlight that these discrepancies are out there, and publications often overlook this. So this is where being a keen reviewer can really help prevent misinformation and really allow for accurate publications. And what you ultimately don't want is a splashy newspaper article saying that hospitals are, or that routine surveillance of imaging in this case is extremely expensive, because that's not true. But nonetheless, I just put this in here as just an example of kind of what the discrepancies are out there in the literature. So that gets us to kind of the my area of research, which is price transparency. And I'll define what price transparency is and why this is such a big deal, and give you some history behind that, and then some of the work we've done around it. So I put this quote in here. This is a quote from Ezekiel, or a paper that Ezekiel Emanuel wrote, in which he summarized a late economist, Hugh Reinhardt's perspective on the U.S. healthcare system, in which he compared it to putting a blindfolded crowd of people in a store, instructing them to buy a shirt, and billing them for that 6 months later for whatever they grabbed. And a lot of that is in reference to the fact that patients, providers, really anyone in the healthcare system has no clue how much folks are actually paying for the services that are rendered. And that, fortunately, has now changed. But before I get to how it's changed, an important question to answer is why even have transparency in healthcare costs and prices? So arguments in favor are that if you disclose how much something actually costs, it empowers the decision makers, in this case, patients. And certainly in America, the system is such that it's more so of a consumerism-based market, a capitalistic kind of system, whereby patients are the ultimate decision makers and decide who they see and potentially may account for cost as they make those decisions. And the overall goal of kind of disclosing price would then be to stimulate competition, lower cost, and increase quality of care. And of course, decrease that information asymmetry that historically has always been there, with the ultimate goal of achieving higher value care. Those against price transparency feel that transparency is somewhat misguided. And this has occurred in other settings, mostly in this individual state setting. So in New Hampshire, studies have found that only 1% of folks actually used a transparency website in the first 3 years. And in California, there was no association with price transparency and healthcare spending. And some also argue that physicians, not patients, are really the decision makers. They're the ones, spending or deciding what test to order, who to refer to, et cetera, for at least a significant majority of types of various medical procedures or testing. And so therefore, it's not really relevant for patients to have access to that information. But nonetheless, this is kind of the context in which a lot of debate occurred. And ultimately, in July 2019, Trump signed an executive order mandating that hospitals disclose price, and these are, again, negotiated prices based on payer negotiated rates for ultimately all services rendered by a hospital. And this had never been done before, as I mentioned. So we've only ever known how much someone charges, and that's kind of based on Medicare rates, but we've never ultimately known how much an insurer actually pays for a procedure, a lab test, a visit, et cetera. So there's a lot of debate, and ultimately there was a period of time in which anyone could really submit kind of their thoughts or complaints, a public kind of hearing of sorts, and ultimately the American Hospital Association did sue the Trump administration, but ultimately this was dismissed through the U.S. District of Columbia Circuit of Appeals. And in January 2021, the price transparency rule went into effect, essentially mandating that all hospitals must disclose prices for all services rendered. And that's ultimately what happened. So this led to the final rule called the Hospital Price Transparency Rule. Again, went into effect in January of 2021. And each hospital was required to provide, quote, clear, accessible pricing information online about items and services they provide. And the Centers for Medicare and Medicare Services were tasked with enforcing this or stating what needed to happen in two ways. One is that all hospitals needed to have a publicly available machine readable file, which ultimately wasn't clear what this, well, there's a lot of, kind of interpretation about what that could be. But there did also have to be a display of shoppable services in a consumer-friendly format. And there was a penalty. There is a penalty for hospitals that do not meet this mandate. We'll get into that in a second here. But nonetheless, this was the mandate, and it went into effect on January 1st, 2021. So I just want to emphasize that this was completely unprecedented. So no time in the history of the United States kind of healthcare system have we ever known how much payers pay, meaning insurance providers pay for, again, all these procedures. Previously, this was all kind of behind closed doors bargaining that none of us had any access to. But through this transparency rule, a consumer-friendly list of at least 300 shoppable services was mandated. And the rule actually specified 70 specific services and then left the remaining 230 to be selected by each hospital. As I mentioned, there are penalties for non-compliance. So they have kind of staggered this based on size of the hospital, again, to decrease kind of inequities that small hospitals might have a higher burden of kind of failure to report. But so for small hospitals, about $300 per day, and for large hospitals, up to $5,500 per day. And that actually went up just because non-compliance rates were quite high. Oops, let me go back here. So this led to a lot of interesting press. So Sarah Cliff is a New York Times reporter, and there are a lot of splashy headlines when this rule went into effect, because again, this data was publicly available. So anyone and everyone, including investigative reporters, were really all over this. And anyone could do it. And the bottom right, you can see, within Boston, we have a lot of different hospitals within a very small radius. And even within those within that 3-mile radius, there are significant discrepancies in how much things cost. So this was somewhat groundbreaking and a very made for very splashy headlines. This was one of them from the New York Times as well, kind of a big editorial page, just showcasing how different the price, for example, an MRI was at Mass General Hospital, from just over $1,000 with Cigna to over $3,800 with a Humana plan. So, this definitely left a lot of food for thought and stimulated a lot of interest among clinical researchers, including myself. I'll just put up an example of my hospital, the Brigham and Women's Hospital website. So they are compliant with this rule. And this is kind of what that looks like. So on the left, you'll see just a blue button where you can click and download a 260 megabyte file with essentially it's just a .csv file. So to the layperson, completely uninterpretable, but they do have some estimates through a kind of friendly landing page on the patient gateway. The Biden administration has upheld this rule, and remember, each administration can kind of take it down or keep it, and ultimately Biden did uphold that Trump rule, but he did also increase civil penalties for non-compliance, and that's where that $5,500 per day penalty actually came from. But he also did provide some incentives for reporting, specifically among kind of lower income areas and hospitals, and he also required that the changes in ownership and actual ownership be disclosed, essentially kind of increasing transparency, if anything. And this kind of came under a bunch of different laws. So now we'll kind of turn to some of the research we've done in otolaryngology price transparency. And again, this was kind of an exciting time for us around January 2021, because all this information suddenly became available. So we've applied some interesting methodology to kind of really exploit that data and answer some basic questions just about how much do things actually cost, and how different is it between hospitals and even within the same hospital based on one's insurance plan. So you'll see these two folks in the top right quite frequently. These are two residents at Mass Eye near Harvard Medical School who've actually done the lion's share of this work, and I'm very lucky to be able to work with them. But you'll see their faces quite frequently here. But this was the first publication we had actually in JAMA, and this was our first kind of foray into it, kind of more from an otolaryngology perspective, but looking at negotiated prices for management of thyroid cancer in 2021. This was a cross-sectional analysis of commercial payers' negotiated prices for really multiple services around thyroid cancer management. We specifically chose National Cancer Institute designated cancer centers just for some homogeneity in terms of kind of the types of hospitals we were querying. And we essentially compared prices using these two concepts, across center and within center ratios. So what we did is we defined, we went through each, the median price, and we did normalize for a variety of different things, such as wage indices and kind of different factors that are related to local markets. But once we'd normalized, we looked at the 90th and 10th percentile in terms of highest and lowest prices, both within a facility and then between facilities, to come up with a ratio. So the higher the ratio, the bigger the difference between those two extremes. And the smaller the ratio, the narrower that difference. And that allowed us to kind of create some comparisons in terms of how vastly different are prices for the same procedure, same service. We also did in a lot of these studies just look at compliance. So how compliant are different centers with this new rule? So to give you some of the data here in terms of compliance, really for any service we looked at related to thyroidectomy, it was about 50%, so not high. For the total thyroidectomy professional fee, the compliance rate was quite low, only 15%. But again, this was kind of our first gestalt of what's really going on after this rule, and this was about 6 months after that rule came out. But notably, there was significant discrepancy in terms of cost. Now, this is a busy table, but we looked at a bunch of lab tests, radiology tests, treatment, including radioactive iodine, surgical procedures, and inpatient care. And I'll direct your attention kind of to this payer negotiated price here. So again, these are the median prices. We did also have means, but if you look at that interquartile range, it is extremely high for some things. So for example, radioactive iodine, anywhere from a median price of $342 to $1,312. And you can similarly see just how widely different it is for different types of procedures and services. So again, it was somewhat eye-opening for us because we'd never seen these numbers before. And to see that huge discrepancy for the same exact thing between hospitals and within hospitals was really quite eye-opening. So again, if you look at radioactive iodine, 70-fold difference in price for the same exact procedure between different hospitals. So if you went to hospital A as a patient compared to your friend who went to hospital B, you might expect to pay 70 times more than your colleague or friend at hospital B. So that's very sobering. So this led to other studies. And again, obviously, me being an otolaryngologist, my interest has been in how this affects a lot of the prices for otolaryngology procedures. So this was a study we looked at just payer negotiated prices for common outpatient otolaryngology procedures. So again, this was a cross-sectional analysis. We restricted it to US News and World Report ranked hospitals. And again, looked at those two ratios. So just to remind you again, a cross-center compares median prices between different hospitals, and within center is really just comparing different payers within the same institution. And the bigger the ratio, the wider the extremes in terms of highest and lowest median cost. The disclosure rate in this case, again, compliance was really low, and that's you're going to see as a common theme for a lot of these different studies. But this is again a busy graphic here, but we looked at rhinology, facial plastic surgery, otology, laryngology, head and neck. And the bigger the blue bar on the left, the greater the price discrepancy between different institutions. And on the right, again, that within center, meaning how do different insurance payers compare within the same institution, again, quite variable. Oops, sorry. So it's just really, it's quite fascinating how variable the prices for the same procedure, both within and across different institutions. And I'll again just emphasize that this had never been reported before, and this was all just kind of new, really fresh information for us to kind of sort through. These are some of those raw prices that I think are really interesting to see. So if you look at the median payer negotiated price, so at for some institutions, let's take the example of like a hemithyroidectomy, as cheap as $1,520. And I should say cheap, it's not really cheap, but $1,520 up to $14,000. So the exact same procedure, why are two different hospitals charging such vastly different amounts? And there's a lot of different explanations for that. We won't necessarily get into that today, but a lot of food for thought. And within our field where there's just so much breadth in terms of what we do, again, very humbling to see these differences. We did look at this in the context of telemedicine as well, just kind of around the COVID era and during the public health emergency. Obviously, a lot of telemedicine use. So we looked at 8 different telemedicine codes, and disclosure rates were a little higher for this, 67% actually, but nearly a 4.5-fold variation in telephone service price across different centers. So again, to orient you, on the left is kind of the raw median negotiated price for these varying procedures. This middle bar graph is the ratio across centers, so how different are two different centers across the country, and then how different are insurance payer reimbursements within the same institution on the right. Asynchronous just means that a service is provided separate from the time a patient's actually seen. And then synchronous is for example, you're talking to a patient directly and managing things as they tell you what's going on. But what was interesting about this, as you can see here, is that the prices for telephone encounters were significantly higher than they were for online visits. And this did raise the question of how does this affect patient populations who don't have access to internet or other kind of online mechanisms, broadband internet, whatever it is. And so that was kind of an interesting finding that we found in this study. We've looked at this for pediatric otolaryngology, and this is where we started to get a little fancier because we started doing some more in-depth analysis, kind of looking at predictive factors, so using multivariable regression analysis to see what predicts higher cost. And in this case, we focused on just 2 procedures, pediatric tympanostomy tube placement and adenotonsillectomy, again, cross-sectionally just in the year 2021. And in this study, we found that prices, again, were quite variable. And this was true both within the same institution and across different institutions. And I'll just point out that at this point, there's a company that came out called Turquoise Health, which actually did a lot of the data and mining for us. So remember I said that that rule only mandated that institutions publish a machine readable file. So all the work that you've seen done in these different studies required a lot of labor. So Roy, one of our residents, had to go through, download each hospital's .csv file. And remember, these were just kind of a chaotic mess of different codes, and actually distill them down into usable data. But with Turquoise Health and other companies that kind of took advantage of this rule, we ultimately did pay a membership fee for this, but we were able to download much more data in a much more interpretable, analytical manner. So this company and others have really taken advantage of this rule, but it's certainly helped healthcare researchers like myself. But again, as I mentioned in this specific study, we looked at predictive factors. So I'll direct your attention to kind of these 2 findings right here. So this is a table looking at hospital characteristics in a multivariable regression to predict higher negotiated price. You see a beta coefficient there. So the 2 significant predictors of higher price for adenotonsillectomy, in this case for children under 12, was geographic location of a hospital in the South and for-profit versus not-for-profit. So this somewhat makes sense in that for-profit hospitals will likely try to have higher margin operating budget, and therefore will be more likely to charge more. The geographic variation is less clear, although if you think about the Northeast, for example, a very saturated healthcare market, perhaps there's more competition and therefore prices go down. We didn't really find any significant association of within a center, meaning kind of between insurance providers. But these two findings on the left certainly did pique our interest. To summarize this study's finding, we found, again, a low compliance rate for kind of disclosure, so just 40% for this, and just a huge price discrepancy for and I've listed the prices for myringotomy and tympanostomy tube placement, and then very high within center ratios. So moving on to head and neck, which is my area of expertise, we also looked at various surgical oncology procedures. We looked at 10 commonly performed head and neck procedures, again, using the turquoise database to really do a lot of the lion's share of the work for us. We use the same kind of concept of across and within center ratios. And again, also to do some multivariable analysis to look at various hospital market factors that might impact or be associated with higher price variation. I think it was a total of 800 hospitals that we looked at, and again, disclosure rates were not super high. But in this graph here, oops, look at that, very similar to the ones I've shown you previously, but significant variation for all the different procedures. The highest for superficial parotidectomy. And then, as you can see, it again was quite variable. For example, 4110, which is a partial classectomy, just had a significant variation between different hospitals, probably the highest of any procedure we've seen. This is part of the multivariable analysis we did. A somewhat busy slide here, but if you look at the top on the right, you'll see kind of ownership status and how that's predictive for each of the different types of procedures. And for direct laryngoscopy, for parotidectomy, for partial classectomy, there was a significant difference in terms of median negotiated price between for-profit and nonprofit, with for-profit having significantly higher prices. Again, not too unexpected and similar to our findings in the pediatric paper. Similarly, location of the geographic Northeast, and that's in blue, was lower cost than anywhere else in the country. So again, very similar to our prior findings, and again, more food for thought. This is an interesting study that Roy, one of our residents, led along with a couple of others, looking at pricing of cochlear implants. And this is what's very cool about this data, is that we can actually look at the price that hospitals charge for various cochlear implants. And I'll show you some of the data here. So these were kind of the three big companies in cochlear implants. You have Cochlear Limited, Med-El, and Advanced Bionics. And the prices are quite high, as we know, but again, I'll focus your attention on the range here. So it's just vastly different for the same device between different institutions. So again, just crazy that a patient at one hospital could pay half as much as a patient at another hospital for the same device. But there were some other interesting kind of subtle findings that we found in this specific paper. Again, here, this is just showing you kind of the difference, the same kind of set of graphs here, but it's really this slide that's interesting. So what we did is we looked at hospitals that only had 1 to 2 brands, meaning they only offered Med-El, for example, and compared it to hospitals that offered 3 brands. So for the Advanced Bionic device, if that hospital, that hospital is offered 3 different brands, then the price for that specific device was significantly lower compared to an institution where only 1 brand was offered. So this kind of makes sense. If there's a monopoly for one device at a single institution, there's going to be a higher price for that. Whereas if there's competition, it goes down. So it's just nice to kind of see how hospital competition might be, or competition between devices at one institution can have this type of effect that you'd expect to see. But again, one of the benefits of doing this type of analysis is that we can start to see these trends And again, this really wouldn't be possible without price transparency. So again, an interesting finding. And then finally, we did look at facial plastics and looked at negotiated prices for reconstructive surgeries, looking specifically kind of at the reconstructive ladder, essentially, by primary closure, skin grafts, adjacent tissue transfer, regional flaps, and free flaps. What we did here a little differently than some of the other studies was we looked at the markup. So you can get a sense of how much Medicare reimburses, that's publicly available information, and then compare it to what hospitals ultimately priced out these different procedures. And the markups were significantly higher for kind of the simpler procedures, which again, perhaps makes more sense just if they're offered in the cosmetic setting. But another application of this type of data. There were some obvious trends as well we saw in multivariable regression. So again, for-profit hospitals have a much higher price markup than not-for-profit. Urban hospitals are slightly less than rural hospitals, perhaps because they, just have more competition. And again, the Northeast is generally a location where there's more competition and likely that drives down prices. So what is the point of this and kind of what's the future? So I'll go over kind of a couple of different thoughts and findings, but as you've seen, that there's a wide variation in terms of price, both within institutions and across institutions for the same services. And that's, I think, an important finding and one that's kind of perhaps obvious, but now we've kind of really put it out there in numbers. So everyone can see this. And it is really quite fascinating that you have the same procedure, likely the same outcomes, yet vastly different prices. Consumers and patients really can now determine the cost of their care through easier online tools. And the question remains, is it really going to impact their decision-making? But nonetheless, they have access to all this information. And then somewhat selfishly for researchers like myself, this is just a huge breadth of data that's very valuable for us to use. And it's also quite interesting that disclosure rates are really quite low for most of the hospitals, and many of them remain non-compliant. Is somewhat of an aside, but interesting note, the CMS has published some of their enforcements. So you can actually see which hospitals have been fined for non-disclosure, and these are some of the ones listed, as high as $800,000 for Northside Hospital in Atlanta. But whether that affects the bottom line of that hospital or not, I'm not sure, but nonetheless, it is being enforced. And so that leaves a lot of lingering questions too about some of the implications of the findings I've mentioned and what we do next in terms of future research. So has it lowered commercial prices? And as I mentioned at the beginning, the idea of price transparency hopefully would be to decrease expenditures, decrease price, and increase competition. And the idea of doing this might allow, with hospitals knowing how much other hospitals charge, maybe there's some benchmarking, meaning they can compete against each other and lower their prices to meet the kind of lower price listing of some of the high competition hospitals. And ultimately this should lead to lower costs and reduce healthcare costs. But I think that again remains to be seen, and likely it's too early to know, but an important question for us to answer. And another one I had was kind of, why is compliance with this rule very low? And it could be that the costs are too high to implement it, or there could be concerns about negative implications that may trump the penalty, despite even raising the cost of the violation. And as I've alluded to many times, what explains this large variation? And it could be a number of different things, which we are kind of working on studying, but it could be contextual factors and characteristic of health plans. And there's certainly a lot of strategy involved in terms of how hospitals price things within a certain market, but there's probably a lot more here than meets the eye. A couple more questions. One, are patients better equipped to make more decisions? So does a patient understand that perhaps by going to a hospital that charges more, there are other benefits, meaning maybe that hospital uses that increased kind of revenue margin to support fellowship training, residencies, et cetera. So could those go by the wayside if patients are really just focused on the cost of something? Are there implications for diverse and equitable care? Again, as I mentioned, smaller hospitals may be overly burdened by these by the non-compliance fees, et cetera. So how is diversity and equitable care impacted? And then what impact does price transparency have on patient outcomes? So ultimately, you want higher value care, meaning low cost and better outcomes. So what is the impact on patient outcomes? And again, this is kind of a long-term question that we're working on analyzing. And then finally, what market factors might predict variation in pricing? And I've answered that somewhat today just by explaining some of the geographic variation and for-profit versus not-for-profit. But there's likely a lot more that explains it, and kind of going back to my original paper on hospital competition, certainly there's probably a large effect of kind of regional market factors. So lastly, I'll just conclude by kind of giving some thoughts on how you might approach a paper that you see in your review in Basket, and kind of how you might think through some of these concepts that I've presented today. So first is kind of a basic question that I think all of you should now be equipped to answer is, are the correct definitions used? So did the paper accurately define what charge is, what cost is, or what price is, and were those applied in the correct setting to whatever that manuscript is kind of suggesting? And I really think that's important to emphasize because as you've seen here, you really can mix things up, and I think the implications are quite significant. So charges, of course, will be much higher than cost and should never, ever be used as a proxy. So I just encourage you to kind of think through those definitions very carefully. The other thing that I didn't really emphasize too much here, but you want to normalize things and adjust for kind of known differences in local, regional, economic atmospheres. So we did use things to normalize kind of cost differences or wage indices differences. For example, perhaps the Northeast has to charge more because the wage index is much higher. So some basic economic principles really do come into play, and you want to look at a paper and see, have they thought through this, or is it just a kind of data mining exercise? So you really want to be careful about kind of looking for that. The other thing is just start, it's always a good practice to think about where's the data coming from. Is it kind of a random review of some website that happened to publish something, or is it kind of a government-funded website like the Agency for Healthcare Research and Quality? Is it, in this case, for a lot of the price transparency coming directly from the hospital, or is it a reputable kind of database like the Turquoise Health database? And this is probably a practice that's relevant to really any paper you review, but I'd highly encourage kind of querying that. Looking at the methodology, so does it make sense? So kind of the within center and across center ratios that I've described in a lot of the work we've done, that has really stemmed from other similar papers, and kind of all the big groups out there that do this type of work have really use the same methodology. So you want to make sure there's some consistency in how a paper is kind of approaching a complex question or a simple question even. Is the data generalizable? So, this is again a principle that's relevant to really any paper you review, but did they use one institution to extrapolate to many others? Whatever the case may be, you want to always have that question in the back of your mind. This is numbered incorrectly, but ease of data communication, I think, is also something that's really important these days. So this is somewhat of a complex topic to teach or kind of present in a manuscript to folks who really have no exposure to it. So you want to make sure that that data is interpretable, that it's easy to understand in a figure, and to be critical in those areas. And again, I think it's a general principle, but really any scientific findings need to be presented in a coherent, easy to communicate fashion. And then I'll lastly just end with kind of how you can pursue similar research. And again, I'll emphasize that all this is completely out there and is publicly available. Most institutions consider publicly available identified data exempt from IRB review, which does take away a big hurdle in terms of research. So something that anyone can easily do, and hopefully this can stimulate kind of your thoughts and efforts in doing something that's relevant to your specific field of interest. And a lot of the analysis I presented today is really not complex, really just statistically based on simple t-tests or chi-squared analysis. And more of the efforts are just encoding, whether it's using R, Stata, whatever your software of choice is. But that's kind of where expertise in just managing big data comes into play. And then finally, just think of questions kind of relevant to your field. Find something that piques your interest if you're interested in this. And there's likely many, many questions still out there, as I've mentioned, and many interesting answers that we have yet to find. So I'll end with this quote that I presented earlier. I think we're less blindfolded than we used to be, but it remains to be seen kind of what the implications of all the price transparency is. Are blindfolded crowds more likely to buy the cheaper shirt, or as an analogy, go to a hospital that offers a cheaper price for, let's say, a tonsillectomy? Again, that remains to be seen. So I think a lot of interesting kind of long-term research will focus on that end of things. With that, I'll just say thank you to all of our collaborators, specifically our two residents, Vinay and Roy, who've really done the lion's share of this work, and collaborators across the country, including medical students in the Brigham Women's Center for Surgery and Public Health. But thank you all for listening. I know that was a long hour, but I'm happy to take any questions. But yeah, thank you.
Great. Thanks, Dr. Sethi. Definitely appreciate your thoughts. I see you've already got some applause from the crowd. Any questions for Dr. Sethi? You've got a real expert here. If any of you would like to pose any questions or clarifications, thoughts, either for reviewing papers or, as Rosh described at the end, even studies you might be thinking about on your own. Okay, guess a little bit of a quieter crowd today. That's okay. I think that Rosh, you must have explained everything so great. Everyone can
exactly
understand it. So,
I have a quick question, if you don't mind.
Oh, Robbie, please go ahead. Absolutely. You're more than welcome.
I guess first, thank you for that presentation. Definitely a topic I don't know much about, so that was interesting. So for these, I guess these CSV files that they post on hospital websites, is that does that just include price information for like hospital administered services, or if a private or a private practice that contracts with the hospital and does surgery at a hospital, would the prices for that private practice also be posted there? I imagine maybe not.
Yeah,
and do you think that would kind of skew the price data at all that you're seeing if you're not capturing that?
That's a good point. So this is all really hospital based. So it's nothing. So for example, if an ambulatory surgery center where various practitioners come into, I think there is a push to kind of get that data out there, and I suspect that's coming. But no, it would not include that. That's why I think this research is probably more applicable to some of the bigger inpatient procedures or services. But to your point, it does not include kind of private practice based procedures or services.
I have a question.
Go ahead, Rohit.
Hey, Dr. Sethi, do you have any other good resources for just kind of getting more information on this topic? I mean, I imagine like as a reviewer trying to or getting an article around this and just trying to refresh, memory on these topics. I think it'd be nice to have, easy to go to resource, especially if we don't have a ton of experience in this area.
Yeah, it's a great point. I think there's probably a good number of review articles out there, but beyond that, I think the Center for Medicare and Medicare Services has a lot of useful information because it really distills it into language that's relevant to patients. And I'd argue for just a basic reviewer kind of perspective, that's probably all you need just to understand some of those basics. But there are some good review articles I can dig up and kind of send to the group after. But certainly there's a lot of information just publicly available. And then kind of some more kind of deeper dives through some review articles. But I would definitely encourage you to read or go through the other journals you may have not kind of ever thought to pick up, like Health Affairs being one of them, to look for some of this more nuanced kind of guidance about how these concepts work, but also in a more accessible manner, because there's some really good just kind of basic review articles about this out there. But that's a great question.
Great, thank you.
Great, Rohit. Thanks for the question. And also, Robbie, any other questions for Dr. Sethi? All right. Well, we are glad you all could join us.